came to us from Memphis. He did his medical school in Osmania Medical School in India, and after that he pursued his medical residency in St. Barnabas Hospital in New York. Following that, he did transplant hepatology fellowship at Memphis at Methodist Transplant Institute, and then went on to do gastroenterology fellowship in Memphis at the same time. So he is both a transplant hepatologist by training and a gastroenterologist. We're very pleased that he joined us in summer of 2018, and he's been really spearheading our hepatology program here with his hepatology training. So he's going to talk about management and updates in non-alcoholic fatty liver disease. So before we waste any more time, we'll welcome Dr. Parsa.
Hello, good morning. Thank you, Dr. Kalun, for your kind words. Good morning to everybody, and I welcome to the Grandrounds. Today's topic is management of non-alcoholic fatty liver disease. So my goals and objectives for this presentation, I will be discussing the etiology, pathogenesis, and pathogenesis of non-alcoholic fatty liver disease, and also we'll discuss briefly diagnosis and management options, and also I will be touching upon on the latest advancements in management of NAFLD, and also I will be discussing the latest ASLD guidelines that were released in 2018 pertaining to the diagnosis and management of NAFLD. I don't have any disclosures. Before going into the presentation, I would like to introduce few terms which we use them loosely. Non-alcoholic fatty liver, it's just a presence of steatosis or fatty change more than 5% without any hepatocellular injury in the form of ballooning of the hepatocytes or fibrosis. That's called non-alcoholic fatty liver, or routinely as we call fatty liver. And then the NASH, you have more than 5% of fatty change, together with evidence of inflammation and hepatocyte injury or ballooning. You may or may not have fibrosis. That's NASH. Obviously, cirrhosis is when it progresses to fibrosis and cirrhosis. So any of these three conditions can be referred to NAFLD, or non-alcoholic fatty liver disease, ranging from just a fatty liver to cirrhosis of the liver. There is so much of interest in NAFLD because it is emerging as the leading cause of chronic liver disease in the United States, not only in the United States, but even in Asia and other Western countries. The global prevalence of NAFLD is estimated to be around 25%. It's hard to do an epidemiological study on these topics, but there are some estimations depending on the ultrasound data, depending on the national health surveys, and some meta-analysis. They gave a prevalence of around anywhere between 20 to 29%. And when you take the prevalence in adults, referring to age more than 15 years, it comes to around almost 30%. So in our population, it comes around like 80 million currently. There was a modeling study done based on current prevalence of 30 million, and it's projected that by 2030, it is estimated to cross 100 million with almost like 20% growth, 20% growth in the NAFLD cases. When you look at the decompensated cirrhosis and HCC, any liver-related deaths, they're projected to increase exponentially by 2030, and NAFLD will become the #1 cause for liver transplant by that time. Currently, hepatitis C is the leading cause. For the advent of directly acting antivirals, hepatitis C won't be any more problem over the next decade or so, but NAFLD will replace that place. So one possibility in NAFLD, hepatocellular carcinoma can develop even without evidence of cirrhosis. That's why even if you have stage 3 fibrosis with NASH, you will be worried of hepatocellular carcinoma. The pathogenesis of NAFLD is very complex. There's a lot of studies done regarding the molecular mechanisms predisposing to NAFLD. The central, as you're looking at the cartoon, the central mechanism seems to be the dysfunction of adipose tissue. Adipose tissue has a role in the homeostasis of lipids. It secretes a hormone called adiponectin, which is essential for insulin sensitivity. When adipose tissue is dysfunctional, adiponectin is not released, that causes insulin resistance. Then fat is not stored as triglycerides in the adipose tissue. They're released as free fatty acids into the portal circulation. They go into the liver. And liver also upregulates its fat transporter, and all the free fatty acids are transported to the liver. As our diet is becoming more and more rich with fructose and high-fat diet, they also stimulate free fatty acid release and also upregulate the free fatty acid uptake by the liver. The gut microbiome also has a role, with altered gut microbiome, lipopolysaccharides are released, which induces inflammation in the liver. Once the free fatty acids get access to the hepatocyte, the hepatocyte is overwhelmed and the free fatty acids are not oxidized. Then the end products are reactive oxygen species, which are toxic to the cell. They injure the mitochondria, and they put in a lot of oxidant stress on the hepatocyte, which induces a lot of inflammation in the cell. That in turn can stimulate the stellate cells, which induces fibrosis. The liver macrophages, or the Kupffer cells, they switch their phenotype from M2 to M1, which induces a lot of inflammation in the hepatocyte. So that leads to fibrosis, eventually progresses to cirrhosis, then a risk of hepatocellular carcinoma. And also genetic factors. Especially 4 genes have a role in non-alcoholic fatty liver disease, called PNPLA3, DGAT, and also apolipoprotein B100 and MTP1. These are the 5 genes that have a role in the pathogenesis of NAFLD. So this is a projected Markov model for natural history of NAFLD, where once NAFLD is diagnosed, it can progress from F0 to F4, depending on the risk factors, which I will be discussing later. They can change from the fibrosis level from anywhere from F1 to F3 and even regress from cirrhosis. But once they go to decompensated cirrhosis, there is the risk of HCC and liver-related death from acute liver failure or any other mortality related to the advanced liver disease. So once we think of fatty liver or hepatic steatosis, then we need to make sure that there is no alcohol consumption, significant alcohol consumption. So to define a significant alcohol consumption, more than 21 standard drinks, which has about 12 grams of ethanol, which is a standard beer in our market. If a woman drinks more than 14 drinks per week over a 2-year period, that's what is considered a significant alcohol abuse. So whenever you're thinking of fatty liver, just make sure they don't have a significant alcohol abuse over the past 2 years. Most of the times you will get a referral. Somebody will be having an ultrasound for abdominal pain or some other reason. Then you will be seeing some coarse and echotexture of the liver, and you will get referral as fatty liver. They won't be having any symptoms. Their liver test will be normal. Then we need to risk stratify them. We need to see, look into their risk factors. On the other hand, you might have patients who have fatty liver, but their liver test will be abnormal, and they will be having some symptoms related to that. So your approach will be different for both the scenarios. When somebody has fatty liver without any liver test abnormalities or any symptoms related to that, then you should be thinking about alternate causes of hepatic steatosis, either macrovesicular or microvesicular. Look into their some other liver conditions called like chronic hepatitis, Wilson disease, even chronic TPN, some medications like amiodarone or methotrexate that we use commonly in rheumatology, or corticosteroids can induce macrovesicular steatosis. And some conditions called Reyes syndrome or medications like valproate and acute fatty liver pregnancy can induce microvesicular steatosis. We begin with non-invasive testing for fatty liver, but if the liver transaminases AST, ALT are very non-specific. When they are elevated, they can suggest some inflammation in the liver, which we call NASH. There are a lot of markers that were investigated, like keratin 18, which is an intermediate filament protein in the hepatocyte. It can go up in NAFLD, but it's no way specific to that, and it's not available easily in the market. And also there were several panels of biological markers were suggested, but they are not in the use yet. We can often use a panel of labs called different scoring systems, like FibroTest or APRI score, or even NASH FibroSure or NAFL fibrosis score, FIB4 index. They will give us an idea. The importance of these scoring systems is that they have very high negative predictive value. On these scores, if you have a lower value, that is unlikely to be an advanced fibrosis. So we use the scoring systems to rule out advanced fibrosis. Then we have the imaging studies. Ultrasound is the most common test that we use most of the times. That's how we diagnose the fatty liver. But you should have at least 20 to 30% of fatty content in the liver before it's to be diagnosed on a routine conventional ultrasound. We have specialized magnetic resonance spectroscopy, but that's only available in research centers. We don't use it routinely. We have less expensive and readily available elastography, either it's ultrasound elastography or magnetic resonance elastography, that can estimate the fibrosis level. It can also give us an estimate of fatty change in the liver, fat content in the liver. MRE is a little bit more expensive. It needs a lot of expertise, so ultrasound elastography is widely used. So this is a study of ultrasound elastography. There was 450 patients included in this study. They have paired liver biopsies within 2 weeks of having a fibroscan or ultrasound elastography, and they have their AUC is almost close to 90%, and their negative predictive value is also very high. When you keep the cutoff of 10 kilopascals, you can effectively rule out or rule in the advanced fibrosis. If you have kilopascals of 10, which is when the ultrasound waves are propagated through the liver, the more the fibrosis, the faster the wave is. So that's what the elastography catches. So it's one of the tools that's available around, and it's very cheap. It's an alternative for a liver biopsy at this time. MR elastography can come in as 2D or 3D, but 3D MRE is available only in bigger centers. It can estimate the fat content as well as it can tell us the fibrosis level. When you keep a cutoff of stiffness around 3.64 kilopascals, you can effectively diagnose the advanced fibrosis. This is again 3D MRE. When you use 40 hertz of frequency waves, the diagnosis, your sensitivity is almost 100% for advanced fibrosis and specificity more than 90%. On this picture, the more red it looks, the more fibrosis level. Then the question is, when should we biopsy? We have these all non-invasive testing. You should, nowadays we are not subjecting everybody for biopsy as we have these alternatives. But a biopsy is indicated when these non-invasive markers suggest an advanced fibrosis, or if you suspect any other underlying liver disease along with fatty liver. A lot of times you will have a background of fatty liver, but something else or some other condition will be there. So on liver biopsy, you will be looking at specific characteristics. You should have more than 5% of fat content in the liver. And you should be seeing a hepatocellular injury in zone 3, like around the central vein. And you should see evidence for cytoskeletal damage or the Mallory-Denk bodies, which is non-specific though for fatty liver. You can see in alcoholic liver disease and some other liver conditions. And you will see diffuse parenchymal inflammation with lymphocytes and macrophages predominant. Even neutrophils can be seen, so it could be mixed inflammation. And you will see perisinusoidal fibrosis. So these are the 5 characteristics that you see on a liver biopsy when you are evaluating a biopsy on NAFLD. So this one is showing plenty of fatty change, but this one is diffusely spread around. Here is the central vein. Here you see a portal area, but it's diffusely spread. So these are the specific characteristics. This one is just a fatty change or these triglyceride globules in the liver. You see ballooning degeneration. It's nothing but when the hepatocyte cytoskeleton is disrupted, it just swells, called ballooning. So that's what you see characteristically in NASH. Then you see these bodies, the Mallory-Denk bodies, and you can see a larger mitochondria. And also lipogranulomas, where you see a lot of lipid globules surrounded by a lot of inflammation. And you can also see glycogen nuclei, which can be frequently seen in NAFLD. This slide shows the level of fibrosis, stages during the stages of fibrosis. Here he had some fibrosis around the central vein or zone 3. We have some fibrosis in the portal area and also in the sinusoids. There is bridging fibrosis here connecting these zones. This is what F3. So when you come to this level of fibrosis, that's when you are concerned, where they can go into portal hypertension. To standardize the biopsies for any quantitative assessment or for any studies, this classification, this NAS score is suggested, which estimates the steatosis in the liver, lobular inflammation, ballooning, and they give a score from 0 to 8, and also stage the level of fibrosis from 1A until to 4. So to summarize the approach and diagnosis of NAFLD, when either you suspect by ultrasound, it was routinely found, or they have an abnormal liver test, your first goal is to make sure they don't have any other underlying liver disease, and also look for any alternative causes for fatty change. Then you should be looking for any advanced fibrosis. You can use these non-invasive markers like scoring systems. If they score low, then it's less likely to have advanced fibrosis. Then you can decide to either watch them if you don't have any risk factors. On the other hand, if your scoring system show that they might be having higher fibrosis, you have to confirm with an imaging test. You can use either ultrasound elastography or MR elastography. If still questionable, then you can go for biopsy. If you have any other alternative explanation, or if you can't just zero in on fatty change, then you can use liver biopsy. So I just want to say that biopsy is less often used nowadays for diagnosis. So the treatment starts with evaluation of risk factors for fatty liver. The most commonly associated obesity, type 2 diabetes, dyslipidemia, and metabolic syndrome, and polycystic ovarian syndrome. So the significance of fatty liver is when somebody comes with this condition, you should be looking for these undiagnosed conditions. And also there are they are most commonly associated, though less common than these ones, hypothyroidism. A lot of them will have obstructive sleep apnea. We have hypogonadism, hypopituitarism, even psoriasis. So you should be looking for these conditions when somebody with fatty liver. So coming to the management, weight loss is the central central for the treatment of NAFLD. Weight loss, you can do either lifestyle modifications, there are pharmacological options, and surgical options. So for any program that you outline for fatty change, exercise, diet and behavioral modification should be the basis. If you restrict 500 to 1,000 kilocalories per day with moderate exercise, that is 30 minutes of exercise every day, or like about 200 minutes a week, then we have pharmacological options when the BMI is more than 30 or BMI more than 27 with comorbidities. But this is not the accepted standard treatment for NAFLD yet, though pharmacological options are used in obesity in general. And then when the BMI is more than 40 or BMI more than 35 with significant comorbidities, bariatric surgery can be considered. But AASLD does not establish bariatric surgery as a standard option for the treatment specifically for NAFLD yet. If they meet criteria for bariatric surgery because of their BMI and other comorbidities and they have NAFLD, then you can use bariatric surgery. But there are some medications that were tried for weight loss, specifically in NASH. One of them is Orlistat, and other one is liraglutide. They showed some improvement in the liver transferases and also the NAFLD characteristics like steatosis and necroinflammation, even ballooning. There was some change in the NAS score, but AASLD does not endorse them yet for the treatment. So the interesting thing is when somebody loses 3 to 5% of their baseline body weight, you start to see improvement in their hepatic steatosis or fatty change. If they can lose up to 7%, they have improvement in ballooning and inflammation. And once they reach 10%, even their fibrosis can regress. So your magic number should be 10% of baseline body weight. That's when you see significant change in their fatty change and regression in their fibrosis. So there was a lot of interest in bariatric surgery, and there were some studies done to evaluate bariatric surgery in NAFLD, but a lot of them were not done specifically for NAFLD purposes. There are either retrospective reviews, people who have bariatric surgery, and if they have known liver disease, they went back and looked at them, and they have a follow-up biopsy at 1 year. There is a study of 119 patients, which showed that 85% of the patients showed significant improvement in their NASH scores at 1 year. and that change persisted until 5 years. Even a meta-analysis of 29 studies, almost 3,000 patients, they followed those patients up to 5 years after bariatric surgery, and it showed a significant improvement in their histological features. They had a decrease of at least 15 points in their BMI to show this change. But the problem with that is all these studies have a lot of heterogeneity, and a lot of them did not document the steatosis and NAFLD score prior to and after the surgery. So they have few of the 29 studies that have these documented. But still, if you look at all the histological characteristics of NAFLD, you still see some change or improvement, significant improvement. And even their fibrosis has improved significantly, at least in 10% of the patients. So there was a concern if bariatric surgery is really safe in patients with advanced liver disease. When they have compensated cirrhosis and decompensated cirrhosis versus no cirrhosis, obviously the risk of complications is high. Once they become decompensated cirrhosis, almost 16% mortality rate when they have bariatric surgery. So the patients need to be chosen carefully, and they have to be evaluated case-by-case basis when you're considering bariatric surgery for NAFLD. That's the reason why AASLD says it's premature to recommend bariatric surgery as a main or established option, but you have to see if they have any other comorbidities on their BMI before you suggest bariatric surgery. But what I am doing, when a patient comes to my office, if they have morbid obesity, I am educating them, and I am giving an option to see a bariatric surgeon so that at least they will be enrolled in a bariatric program and they will have a structured weight loss program, which can help their NASH or NAFLD. There was a lot of interest in the pharmacological treatment. As we discussed in the pathogenesis, insulin resistance is central to development of NAFLD. So they looked at the studies, or medications which can sensitize insulin, like metformin, looked at pioglitazone, or thiazolidinediones, liraglutide, which is a diabetic medications, and vitamin E, which is an antioxidant. The studies that were done on metformin did not show any benefit in liver histology, even after extensive treatment. So metformin is not indicated for treatment of NAFLD, though that is the first medication that we use for type 2 diabetes. But there is no benefit in NAFLD. Then we have thiazolidinediones. Rosiglitazone is the first one, but it was withdrawn from the market because of its adverse effects on heart failure. Then we have pioglitazone, which acts on PPAR gamma receptors, which can have reverse tissue, adipose tissue dysfunction, and they can decrease the insulin resistance. This is extensively studied. There was a study with 101 patients. They're all biopsy-proven NASH patients. They used pioglitazone, placebo, pioglitazone versus placebo coupled with calorie-restricted diet and exercise. They they followed for almost 18 months, and then they used pioglitazone in both the groups 18 months after. Their primary outcome is at least 2-point decrease in the NASH score or NAFLD score, and also they looked at individual improvements in the NASH characteristics. Interestingly, it showed improvement in the individual NASH characteristics, but pioglitazone didn't meet the primary endpoint. But as it has significant improvement in the individual characteristics, pioglitazone is approved, and AASLD recommends pioglitazone, which I will be discussing the next slide. And there were studies on vitamin E using its antioxidant property, and it's also accepted treatment for NAFLD. But we have to use it at a very higher dose, more than 800 international units per day when you're using for NAFLD. And there is a concern regarding all-cause mortality when used for a longer time, and also risk of prostate cancer, which is controversial though. There are some studies which gave some association, but some refute that association. So the PREVENT trial is a landmark in this aspect, which has studied pioglitazone vitamin E against placebo. It's a study of multicenter 247 patients. The primary endpoint was reduction in the NAS score, and the secondary endpoint was overall improvement in individual scores. This is the results looking at the primary and secondary endpoints. So vitamin E, interestingly, vitamin E compared to placebo has reached the primary endpoint, but not the pioglitazone. They actually set their p-value very low at 0.025, as they are studying two characteristics against placebo at the same time. But looking at the individual characteristics, pioglitazone and vitamin E both have significant impact on them. So AASLD recommends pioglitazone in diabetic patients with or without diabetes, whereas vitamin E is specifically indicated without diabetes, because that was studied only in patients without diabetes. But both these patients should have biopsy-proven NASH, and we should not treat them based on non-invasive markers or based on imaging studies. You have to prove that they have NASH, and you have to document their NAS score before you treat with these medications. And once somebody has cirrhosis, you should not use vitamin E. Then we have a GLP-1 agonist, liraglutide. There was a multi-center double-blind control trial, but it's only phase 2 study. Liraglutide showed some improvement in the individual NAS scores and also resolution of the NASH, but as it's still the phase 2 study, AASLD does not recommend yet. AASLD says it's premature to recommend. Still further larger studies are available. We use UDCA or UDSO, omega-3 fatty acids, but there is no role in NAFLD. They did not show any benefit. So the most important thing in NAFLD, because when somebody is diagnosed, you have to risk stratify them. One of the most common or significant association with the cardiovascular disease, because they will be having all the risk factors, the diabetes, the dyslipidemic, they have high blood pressure, metabolic syndrome. Obviously, they're at risk of cardiovascular disease. So this is one option. I mean, when you for a primary care physician or for a gastroenterologist to refer them to cardiologists and appropriately triage them to evaluate their cardiovascular risk. So one misconception we have is we stop statins as soon as we see a little bit of elevation in their liver transaminases. But it was studied that statin can be safely used in patients who really need them, especially in cardiovascular disease, until their AST/ALT goes up to 3 times the upper limits of the normal. So you expect some elevation when the statin is started, but it is supposed to come down. And if it persistently goes up, or if they develop any signs of liver disease, like they're becoming jaundiced, you see any other signs of advanced liver disease, that's when you stop statin. There is a Greece study that was in Greek patients, about more than 600 patients. About 227 of those 437 patients with cardiovascular disease, and they have elevated baseline liver enzymes. When they gave high-intensity statin, actually their liver enzymes improved at the end of the study period, so which shows the safety of statins in these patients. So this is a cartoon depicting how NAFLD can cause increased cardiovascular disease. There are multiple ways it can increase, because NAFLD itself is a atherogenic state. It can also predispose to thrombosis in the coronary arteries, and also because of the insulin resistance, they are prone for more cardiovascular events. So coming to the cirrhosis and transplant, as I mentioned before, NAFLD will be the #1 cause over the next decade for liver transplant, which outlines the grave concern regarding this disease. And as the bariatric surgery has been also evaluated extensively to either an adjunct before go for the liver transplant or before, so that they can modify the risk factors. Especially sleeve gastrectomy was studied to be safer option for these patients. The post-transplant outcomes are comparable to other patients with transplants. But one thing is, unless their risk factors are modified, a lot of these people get recurrence of their NASH in the liver grafts. So they have to work on their risk factors. And regarding immunosuppression in the post-transplant period, calcineurin inhibitors like Prograf and corticosteroids can exacerbate their diabetes. In fact, can promote fatty change again in the graft. So we have to be careful when you choose immunosuppression in these patients. So now, as we understanding the pathogenesis of NASH, we are evaluating, looking at the specific targets in these pathogenesis, either modifying the insulin resistance or modifying the fibrosis level or inflammation in the hepatocytes, which is leading to NAFLD. There are several medications that are under evaluation currently, phase 1, phase 2, and phase 3 studies. There are 4 medications that are worth mentioning in the phase 3, which have encouraging results, especially elafibranor is one of them. It acts on PPAR alpha and delta agonists, which basically works on the regulates hepatic acid uptake and oxidation in the hepatocytes, and also the beta oxidation of fats and insulin sensitivity. So we have the trial called Resolve It. It's under phase 3 going on now. And we have obeticholic acid, which is a FXR agonist. So FXR is the receptor in the hepatocyte. It has multiple functions, like bile acid synthesis. It also helps with glucose and lipid metabolism, and also hepatic inflammation and fibrosis. So there are 2 phases of this, two arms of the studies. There's one study looking at patients with F2 up to F2 and F3 fibrosis. There is another one looking in compensated cirrhosis. The first part is completed. It has encouraging results. And the second part is underway currently. And we have 2 other medications called senonsertib. It works on ASK1 inhibitor, that is to functions on apoptosis and cell death. Actually, ASK is apoptosis signaling kinase pathway. Their phase 3 studies are going on now. There are 2 studies going on simultaneously. And the other medication is senicrivoric. It works on CCR2 and CCR5 inhibitors. So they work on the macrophages, liver macrophages or Kupffer cells. They work on inhibiting the fibrosis. The trial is called Aurora trial. It's in phase 3 and still going now. So hopefully over the next maybe few years, because it takes at least 5 years for approval of these medicines, we will have something. My guess is most likely we will have either elafibranor or obeticholic acid approved over the next few years for NAFLD. So to summarize, NAFLD is emerging as the leading cause of liver disease. It's replacing hepatitis C. Soon hepatitis C may go away, but NAFLD will be there. And when you think of NAFL, think of identification and modification of risk factors and appropriately identifying their cardiovascular risk and trying to modify the risk factors. And we have to realize that there are only limited pharmacological options at this time, either pioglitazone or vitamin E. And there are some medications that are currently under trial, but it might take some time, at least few more years, to come onto the market. And the role of bariatric surgery is evolving in the management of NAFLD. And as I said, multiple studies are going on with a lot of interest in NAFLD currently. Hopefully we'll have something soon. This is the article that refers to latest guidelines, ASLD guidelines, was published in 2018. I encourage all the residents to go through that. And thank you. If you have any questions.
Thanks for that nice review. I was wondering if you could comment a little bit about the overlap with fatty liver disease and autoimmune markers, and how to sort out, autoimmune hepatitis versus fatty liver.
Yeah. So thanks for that question. So especially when most of the times fatty liver is diagnosed as incidentally. You do an ultrasound for something and then we get those patients. So when you see them, you first risk stratify them, and then you look at their liver tests, if they have any elevated liver enzymes, if they have any jaundice. Then you need to rule out any other underlying disease, so you do all these autoimmune markers. Let's say if you have any positive autoimmune markers, but your imaging and everything is suggesting fatty liver, so the option we have is to do a liver biopsy. So you do a liver, that's one of the indications for a liver biopsy, to actually look at pathology. Because fatty liver, or even like fatty change on biopsies, you can see across a lot of other liver diseases too, even in Hep C, Wilson's disease, a lot of other conditions. But when you see specific histology for autoimmune disease, you have the lymphoplasmacytic infiltrate, their inflammation. That's when you treat the histology. So you try to modify the risk factors, but at the same time you treat the autoimmune disease. So liver biopsy is key here.
Other questions?
One question. You kind of smile about the Markov model.
Yes, sir.
And you talked about HCC development,
Uh-huh.
but it was across all the stages,
Uh-huh.
F0 through F4. So do you screen these patients at all at the earlier stages? Even the guidelines suggest only at F3 or F4.
There is no guidelines now to initiate HCC screen at earlier stages, but F3 seems to be the stage when reasonable. Because if you look at their economic feasibility and all other, when you consider those factors, that's the main factor that you have to consider. If you start screening at F3 and above, that's more cost effective. So even on Markov model, they said once they go to decompensated cirrhosis, F3 and F4, that's when they start to develop HCC. Even that's only 0.4% per year. So. Mm-hmm.
Now, you mentioned the backbone of all this is pretty much insulin resistance.
Mm-hmm.
So if somebody's already using metformin,
Mm-hmm.
you would encourage them to continue using metformin, though it's not even as guideline in terms of treatment.
Yeah, they can continue for their diabetes management. So they said it's not beneficial for NAFLD, but it's not harmful either. So they can continue it. There was some concern if they should continue metformin in advanced liver disease. That's only one concern, but patients without an advanced fibrosis, that should be okay.
My next question is, we keep getting this new term, lean NASH,
Uh-huh.
where people are not overweight,
Mhm.
don't have typical risk factors for
Mhm.
fatty liver disease,
Mhm.
but they still have
Yeah.
fat and elevated liver tests.
Yeah.
So what is the pathogenesis for these? Is this mostly genetic, or is it,
It
gut
seems most-
microbiome?
Yes, sir. It seems mostly genetic. As you can see, the pathogenesis that we understood so far is very complex. And besides the conventional risk factors that we have, There's obesity, diabetes, and metabolic syndrome. There are a lot of genetic factors that I showed. There are 5 genes especially that we understood so far that models all these changes. So in fact, some people may have all these risk factors, but still they don't have NASH. But some, as you mentioned, like even their BMI is within the range, know the risk factors, they get their ultrasound for something else, they show up as fatty liver. So we still need to understand what's going on there, but my guess is genetic mechanism is one of the things that's going on.
Any other questions? Thank you very much.
Thank you. Thank you. Thank you.